excited that you're all here. I kind of geek out on this, so I want to let you know that we're tight on the timeline. And there is a place on the Swap Carve app for interactive questions that you can ask if we don't get time for question and answers. Before I even go into it, I want you to know my intent was for this slide deck to be used as part of your toolkit and a guide for you later on. So obviously we're not going to learn everything. Hi, thank you. That we need about LMNs in 15 minutes, but my hopes is that you can use this as a resource. So who am I? I'm Danielle Rowe-Martin. I'm an occupational therapist, and I'm an adjunct professor at Columbia University. I've been treating for about 18 years as an art therapist and an OT. And my love for LMNs came when I was working in a very large pediatric home care where we worked with a lot of genetic NOS. And we said, well, we need a template to write an LMN. And they said, we don't have one, so we don't write them. We had 500 therapists in this organization. I can't even tell you how many children we had. That never sat well with me. And fast forward in my career, especially with health equity as an occupational therapist, that was not fair. That was not tolerated to do that. And the truth is, as healthcare providers, we're not paid that time that we write the LMNs. And that's part of why, as I've created this in my career and I teach it to my students, this is to try to be efficient and timely for something that you're likely never going to get payment or productivity for as an OT. So I had the pleasure and the humbling experience of being a clinical evaluator at the SMA Clinical Research Center for 4 or 5 years on clinical trials. And this is where I learned very detailed ways to write an LMN, specifically for neuromuscular disorders. And we wrote them for equipment, services, and disease-modifying agents. Typically, our disease-modifying agents were written after a denial, and we were already in appeal status. So again, I made this so it is clear, have some clarity, efficiency when you're working in a broken system. We all know this is a broken system. We can't go around it. Let's work with it. It's a dance. And I'm going to really preface as we go through this, the first step of this dance is to absolutely accept the fact that you will be denied. There is no doubt about it. Do not ever go to a continuing education course where they tell you, follow my formula and you'll get it cleared. Just walk out. There's a season to denial that happens all the time. There's a rhyme or a reason. I don't fully understand it. But once we accept it will be denied, it will be a lot easier for us in the process of appealing it and taking that time and effort to do so. And just recently, I was expressing before with Carla, there's a new thing that I have first saw about denials. I was writing services for a young kiddo who had a very diagnosed neurological condition. To get services for him, he was in foster care, which typically we don't deny anything in that scenario. My state has hired a third-party evaluator to evaluate all letters of medical necessity before they even get to the insurance company. And they held it up for a very calculated timeline of 90 days. So we were no longer retroactive paid. So that's new. And that has nothing to do with how we're writing our letters. This is just the process that we have to learn about. And so that's why I say chaos. We can combat that with structure and efficiency, and I hope that's what you get from this talk today. So I have very much streamlined this system, and I'm going to be really important to say, because I have read over letters that have been written by other therapists, and I have been very fearful for them because they place themselves into fraudulent waters. If you cannot stand behind your documentation in a court of law, do not write it, period. That is how we do documentation. It will come up. And insurance companies now are pulling every other note for that patient, whether it was the neurologist, their physical therapist, their respiratory therapist, their primary care doctor, and they are comparing it to your letter. I had a patient with Pompe, and their primary care doctor said everything was fine. They're developmentally fine, muscular fine. There's no neck extension in this child. We're already seeking AFOs, and I'm fighting the insurance company because primary said, everything's developmentally on course, because they're going to pull these letters. So remember, court of law. And what I say, we'll talk about that later, but in case I forget, that one looks good. In case I forget, part of this at the end is education to the families to read their MyChart, to get onto their notes, and to check if everything was laid out correctly. And if it wasn't, to put a message on MyChart, not a phone call, a message that is tracked with a timeline in our EMR systems to say, please rectify that note. Okay, so I had a professor that used to say, let's go down to like quick and dirty, and that's what we're gonna do, but not Vegas style quick and dirty, just we're gonna go through this. So on this type of setup, when I go through these 10 steps, I have an example on one side of the slide. You're not going to be able to read that now. You will get these slides. It's meant for you to look at later as a guide, just giving you an example of how you would write this. On the other side are the topics. You can use the bullet points as like sentences that you want to cultivate or even paragraphs that you want to cultivate, depending upon what you're writing for. Typically, disease-modifying agents, paragraphs. That's what we have found that works. So we're going to go directly through these 10 steps. The intro of any of your LMNs, please don't ever assume they know what the medical diagnosis is. Never, ever, ever. You have to lay out what that medical diagnosis is, maybe what NIH explains it to be. Then you also really need to explain where in the course of that disease state is your patient. When you think about spinal muscular atrophy, we have type 1, type 2, type 3. They mean very different things. So I cannot just say, they're diagnosed with spinal muscular atrophy. It is a full example of what that neuromuscular disorder is, how fatal it is, and what type they are, and where they are in that progress. I'm also going to ensure that I explain in the beginning intro how many comorbidities they have, and how many comorbidities are associated to this disease, and list their IC10 codes. That's very important. I'm also going to imply, if I have any natural history of the disease course, what that natural history looks like. If I'm writing a letter for Duchenne muscular dystrophy, the natural disease course is death between 20 and 30 years old, and that's what we're going to write in that beginning letter. So everyone reading it understands the impact of what this diagnosis is. Here's my thing. We're going to pull all this information from trusted sources. This is not a publication. So pull it from a trusted source and make it a little easier on yourself when you pull it. When we get into here, we're going to explain all of the deficits that someone may have. And we're going to, like I said, paragraphs or sentences. Are there cognitive deficits? Are there perceptual deficits? Musculature, posture, skin integrity? Are we seeing contractures? This is for anything, equipment, services, disease-modifying agents. Where are they? Paint that picture. What's super important here is sometimes they will even request a photo. I never give a photo unless they request it, but on an appeal, they may request a photo to see that contracture. So court of law, what you describe must actually be there. We're also going to be really careful when you talk about any levels of assistance. Like I said, they pull letters from everywhere. So if you talk about a level of assistance that doesn't match if they're getting home health aid services and what we pulled for that level of assistance, then they're going to cause a problem later on. So be very clear at what the level of assistance is going to be. And no drug, no disease-modifying agent, no equipment, no service should ever say, if you give this, we will have less home health aid hours. You have absolutely no idea what that family is going through and what they need those hours for. And if it's one child with a rare disease among 7 other typically developing children, you cannot do that to a family. So please be careful on levels of assistance. So in the higher level thinking, I'm really going to talk about the bottom line, is what other options have been used. You may actually talk about the step therapy that they may have gone through and why it didn't work. So when I think about the letters we wrote for Spinraza to get risdiplam, we expressed that the scoliosis was so bad they could no longer do an LP. That's why we needed the oral medication. So we had to go through what they have done and why they can't do that anymore, or why this is nowhere eligible for them. So really explaining why it's unsuccessful so that as we continue, they can see that this is really needed. This is my section of logistics, right? So what's the purpose? What is the purpose of this disease-modifying agent? Lay it out. Pull it from the sources. Pull it from the patient education that's provided by BioPharma. Pull it from the publications that are out there. Explain what this medication is supposed to do. Now, the key is that will tie in to all those ICD-10 codes that you listed before. It'll tie into the way you laid out the intro of the diagnosis, that this medication or this equipment or this service is going to do X, Y, and Z for your client. The other aspect here I want to talk about is the future medical purpose. I am very clear to lay out in any of my letters what the future of my patient or client is. If I am seeking out services for Botox, I will lay out that if you do not receive these services, there will be a $100,000 surgery in their history for tendon release. Do not be afraid to say this. Please lay out all the details that you know are medically pertinent to it. Again, this doesn't mean you're not going to get denied, but it definitely will make your appeal easier when you just copy and paste your own letter. So here, somewhere midway in this letter, I need to put a summary. I don't like putting it just at the bottom. I like throwing it in the middle and then another quick one at the bottom, because these letters do become long if you're laying them out, especially a disease-modifying agent. I have never written one less than 15 pages. People get lost in it. So you're going to summarize midway before you go to another topic, just summarizing everything that you've laid out so far, and that could just be a simple 5-sentence summary. That's where you're going to place this. Safety is also a very big part of this, so you can summarize the safety of the patient. Typically, in my appeals for disease-modifying agents, I haven't had to list codes, but in anything else, I have to list codes. I have to list codes that are CPT codes. I have to list codes for every single component of a piece of equipment. I have to list a code for a metal screw. I have to literally write, this metal device has the appropriate tensile strength to connect the base to the seat of the wheelchair for safety. So, once you write codes for something, save them in another document. They're available for you at all times. I listed here just the CMS Gov. That will take you to all the list of codes that sometimes are added. Sometimes in appeals we need codes. I have 5 minutes, I gotta move. So impact. So I'm an OT. I live and breathe ADLs and instrumental IADLs. So if you know of them, please list them. Again, you can pull these from other notes if you're not an OT, but you need to impart how this affects everyday life. Everyday life. Because that is what we have justified, and that's what we have legal services for, to say that everyone has a right to engage in everyday life without the assistance of anyone else. When I go to instrumental activities of daily living, I repeat again the decrease in burden of cost, not for surgeries, but the decrease in burden of cost for them to engage in the community, right? So this might be that they need to engage in the community. They can now become work. They have enough energy and conservation that they can now go to work, and what that means for the community and what that means for their area. I'm going to go back really quick on one thing because I missed it when I was speaking. Nowhere in this note should you ever talk about how it benefits a caregiver. They do not care. That's immediate denial. Immediate. So do not go into how it impacts a caregiver. I will always attach to any of my letters, especially an appeal, a published article. I will cite it, I will reference it, and I will attach it. Every year, I can get hippotherapy for a child with SMA paid by Medicaid in New York State because there was one published case article about it, published in a peer-reviewed evidence-based article. I have never been denied for that. I can't get hippotherapy for anyone else. So this is a thing, and I want to really make this in part. You have my contact, you have my email. I likely have access to almost all the databases at Columbia University. You find the article, send it to me, I'll make sure you have it. There is no reason that you shouldn't be able to attach these. These are important. This is why we publish our research, so that it can make a difference in a client's life. These are just some examples of how we have used policy that's been published and how we have used actual case management and publication tools to be able to ensure that we can get these services. Again, doesn't mean it's not getting denied. In conclusion, you always end with a power statement. Always. So this example of the power statement here that has to do with exact rehabilitation and existing conditions that we fight for under federal law is important. If you can't think of one, a great one is any deviation from this care plan will be a disservice to your client's name. Put the onus back on the insurance company that if they deviate from your medical opinion, this is the power statement. You are going to be in this dance with them. You were never not going to be in the dance, so I want you to continue to be strong and be the leader of the dance. You will go through appeals. Guaranteed. That's going to happen. So what's really important is sometimes you give an option for a peer-to-peer review. The more detailed letter of medical of necessity that you have, the easier it will be for your MD to do that peer-to-peer. You just highlight it, and they can fight that peer-to-peer. They are quite busy, as we all know. So if we make it easier for them, they're easier at the peer-to-peer, and they feel more confident there. The other part you can do is you can do an addendum. Sometimes they ask you questions, they send the appeal and they list the questions, like 4 or 5 questions. You're then gonna do the same way, just this written addendum here. You're gonna put those questions word for word in italics and you're gonna answer to those questions. Sometimes you've already answered it in your LMN. This is just a game. They wanna push off the time. You have to rewrite how you answered it. You have to put it exactly under the question, and then we will go to the next step. This is what happens. Sometimes the next step is approval. Sometimes the next step is another addendum. Please do not let your patients end up with the denial paperwork because they usually get it first. So at all times, I tell my patients and clients, we're going to try to get it. I never tell them we're going to get it. I do not put them through that stress. We will try. And if you get a denial, which we might, please let me know so I have time to appeal it because you have 30 days. Do not let your patients go to the court to appeal it themselves. What will happen if they go without a lawyer is they will say, your PT, your OT, your doctor, your neurologist didn't do this, and we are not there to help them. I have time. Just remember, is it clear? Is it justified? Have you been medically detailed, and was it focused? If you can say yes to all of those, you have an LMN. Stay calm and dance on, everyone. I'm sorry I ran out of time for questions, but please put them in the app. I'm happy to answer them.